It's my pleasure to introduce our speaker today. Joining us, we have Alexandra Kushliak, an educational consultant for advanced care planning, goals of care for the Calgary region of Alberta Health Services. Alexandra holds a Bachelor of Arts degree and a Bachelor of Social Work degree and is a registered social worker. We are so glad to have her joining us this afternoon. Alexandra, I'll turn it over to you.
So thank you, Kelsey. As you can see, my name is Alexandra Kushliak, and I'm an educator with Alberta Health Services with the Calgary region. So happy to be with you here today. It's such a great advantage, and I'd really like to thank Dying with Dignity Calgary for inviting me, because it's such a great opportunity to reach a lot of people. I just like to remind you that advanced care planning and goals of care is not just for people who have medical issues. It's not just for seniors. It is for absolutely everyone over the age of 18. So if you are in one of those categories and have families, children, grandchildren, please pass on this information to as many people as you can. So I just look again to thank you for coming, to taking out the time to take part in this important topic that's actually is for every Albertan. I do remind you that this information is specific to Alberta. So if you're watching from another province, not all the information will apply to your province. So I put up my little mouse because I think that's what we all feel like. We're all a little bit stressed. With COVID coming in, we're all a little bit confused, I think, and we're all worried. So we're all thinking in terms of that we've seen these scenes on TV with COVID. We're all worried that we might end up in the hospital, and that's not something none of us really want to do. So also with this, a lot of news about COVID and hospitalizations, people are thinking, well, what's new in advanced care planning and goals of care? How have they changed? And do I have to know some new information? Well, nothing has changed in terms of the way Alberta Health Services does their policy and procedure and their goals of care on advanced care planning. It still remains the same. And we're lucky in the province of Alberta that we do have a system. Unfortunately, what has changed is that for the first time, the public is actually getting a good look what it looks like to be in the intensive care unit. In hospitals, it's recently a little opened up, but people aren't able to visit their loved ones if they're sick. I wasn't able to visit my mother who's in long-term care for a long time. You know, I had to look at her through the window. Our everyday life has changed. We're wearing a mask, hopefully. Things that we're doing that we did easily before, they're a little bit harder to do. But the biggest question is for everybody's mind is, what can I do to prepare? And so that's a really good question, and it does lend itself to the topic today about advanced care planning and goals of care. So there are risk factors that are associated with COVID. So it's important to know those risk factors because we want to know, what does COVID mean for me? And what can I do to prepare? So I've put up a slide of some of the risk factors, you know, and when I first looked at them, I thought, oh, I'm not at risk. And I looked at the risk factors, and sure enough, you know, I'm older than 60, so I'm in that category. So actually on Alberta Health Services webpage, if you look on the COVID page, there's also has a risk factor questionnaire that you can go through, put in your age and your sex, and that will, and some of your health issues, and that'll tell you the risk of what your outcomes would be if you've got COVID. And of course, it's just a sort of a risk tool. Just so that you know what we're in, I took these stats off from today. So presently in Alberta, we have 112 people in hospital. We have 18 in intensive care unit. We have approximately 3,500 active cases. The average age of death is 84, but that does change as we move along. And fortunately, we've only had 296 deaths in Alberta. I know if you compare that to the numbers in the States, but remember, for every one of those, there's a family behind that. There's families and husbands and wives who are missing their loved ones. So it's not great in terms of COVID. why I want to talk about advanced care planning is that it's going to help us to prepare. So I'm going to go through what advanced care planning is, why we should know it, how we do it, what is a personal directive, what should I put in it. I'm going to go through the goals of care system, what that means for you if you're in hospital, what that means for you if you're at home, and also what does RMNC mean. So we're going to do that. I'm going to show you a few videos. I'm going to talk a bit, and we're going to have a combination of both. So if I disappear from your screen, that means I'm having some connection problems, and then I will stop my video. But you'll still see my slides and you'll hear my voice. I just don't want you to get concerned if you don't see me on your screen. So I'm going to start with this video. This is Dr. Charlie Cork. He's a physician from Australia, and he does a really great job of explaining what advanced care planning is and why it's so important.
About 80% of people at the end of their life are in a position where they can't make their own decisions. I'm Associate Professor Charlie Cork, and I'm a specialist in intensive care medicine. Some people will say that my family know what to do, or my doctor will know what to do, and unfortunately they're wrong. When a family's got an advanced care plan and knows what their relative wants, it's enormously easier for the family because they haven't got all the responsibility of making these, what they see as impossible decisions. And it makes it ever so much easier for the doctors because doctors are trying to do the right thing. They just need to know what it is. I think advanced care planning, in a nutshell, is three important things. It's about thinking about it, and just thinking about it starts the process happening. Talking about it to your family, talking about it to your doctor. The third thing is picking a great decision maker. Because 80% of us, right at the end, will not be able to make our decisions. Just at the end of life, the way the process goes, you're not able to make decisions, and decisions need to be made. And a great decision maker is able to talk to the family, talk to the doctors, make a decision, make the right decision for you, and to feel comfortable about it. And it makes the whole process so straightforward, so controlled, and so sensible. And that's really, really good.
So although Dr. Cork talks about end of life, I want you to remember that advanced care planning is for everyone, like I said in the beginning, everyone over the age of 18. I want you to think about if you were in a car accident and you landed up in the hospital, who would make decisions for you if you couldn't tell us what you wanted, and would they know what you wanted? We have a lovely video on our website, Conversations Matter. On Speak Up, the National Advanced Care Planning website, where our doctor, Dr. Amy Tan, who is working in Calgary right now, talks about getting into a car accident on her way to the emergency unit as a physician, and she ended up there as a patient. She had not talked with her husband about what kind of care she wanted. She did not have a personal directive. And so now, luckily, she came out of it fine. She has a little boy and she is doing fine now. But she teaches all her students and other family physicians the importance now of advanced care planning and having that personal directive. So advanced care planning is that process of thinking about and sharing your wishes for healthcare with people close to you. So it should not be no surprise about what you want, and choosing the right person to make those healthcare decisions. And in the province of Alberta, that's called your agent. And then we write that information down in a personal directive to make it legal. Because behind the personal directive is actually a personal directive act where it makes it legal. It also has obligations for the agent. It also has obligations for us as healthcare providers. So we're really lucky in the province of Alberta to have that. Maybe you've never heard of advanced care planning before. Maybe you've never heard of the personal directive before, but you're not alone. And we have an issue across Canada. So 93% of Canadians think it's important to discuss their healthcare wishes with family and friends, but only 36% of us do it. So we're thinking about it, but we just don't take that extra step. 80% of us think it's important that we talk about what our healthcare issues are with our physician and our healthcare team. But again, look at that stat, only 8% do it. 66% of us think it's important to discuss it with a lawyer, but again, not very good, only 7% of us do it. You'll be happy to know that in Alberta, 40% of people have a personal directive. So if you do have your own personal directive today, I do want you to review it, and I'm going to go over that and why you should be reviewing it and looking at it. So if you're still not convinced why we're in such bad shape with advanced care planning and people writing their personal directive and talking to their physician, if you're anything like my dad used to be, he said, well, what's your big deal? I have a will, I'm good to go. What kind of decisions are to be made? Well, if he died in the 1950s, he would have been right, because in those days we didn't have a lot of fancy bells and whistles. We didn't have all the medications that we have now. We didn't have all the choices. And most people, when they got really ill, it was only about a short time before they died, approximately 2 weeks in those days. We look a lot different now in terms of how we die. 85% of us will die in one of these fashions, whether it's through terminal illness, whether it's organ failure or frailty. And if you look over at the graph, so over that time, lots of decisions have to be made. So we have people that are in long-term care for 10 years. And over that 10-year period, they have dementia and they're not able to make their own decisions. So the question is, did they talk to their families about what they wanted? Did they pick a decision maker? And does that decision maker know what they wanted? So unfortunately, my dad ended up in one of these graphs. He had a stroke. And it was 2 years before he died. And during that time, decisions had to be made. Who's going to look after him? Where is he going to be looked after? What kind of medication is he going to take? Would rehab help? Who takes him to rehab? All those decisions had to be made. So these are the 5 steps that we teach in Alberta Health Services for advanced care planning. The first one is think about your wishes and values. So think about what's important to you, what makes you you, what makes you different from your neighbors and maybe even different from the rest of your family, what's important to you. Number 2 is learn about your own health. Do you know what's coming down the line for you a month from now, a year from now? Do you understand when your doctor says you have diabetes? Do you understand what that means? Do you understand the medications that you take? So it's really important to understand what your health is. Because if we don't understand, it's a little hard to plan. If you knew that this Christmas was going to be your last Christmas, I bet it would look a lot different than if you knew you had 10 or maybe 20 more Christmases to go. So we need to know where we're going before we can plan. Choose someone to make decisions and speak on your behalf. So that person needs to be someone that you trust, someone that can make decisions for you. I always have that 80-year-old woman who says, you know what, I'm going to have my husband as my decision maker. But if he's 90 and in poor health, not a great choice. So we have to think, who would be making decisions as if I would? Who would be that advocate for me, who would make sure that what I wanted would be followed through on? Number 4, even though down the line, I think it's the most important one. These things shouldn't be a secret. We want you to communicate your wishes and values to your family, to your friends, and especially to your healthcare provider. Because if something happens, your family should know, or your friends should know what you wanted and who's going to follow through on those wishes. And where we make it all legal is in that personal directive. So that's the final step, so that you have an actual law that will make sure that your personal directives is followed. So I want to make it really clear, just like my dad was, that a personal directive is not a will and it's not an enduring power of attorney. So a will is only looked after you died. It's for your estate and for your money, so we know who you leave your great stuff to. An enduring power of attorney is only for money matters and your property. So an enduring power of attorney appoints someone to to deal with your money while you're still alive. So in the province of Alberta, we need all 3 documents. We need the will, we need an enduring power of attorney, and a personal directive. So for some of you who say, well, I have a will somewhere, have a look at your documents, because you might also have a personal directive in there and an enduring power of attorney. I know when I went to have my personal directive done, the lawyer did all three of them at once, and then he gives them all back to you, or actually my lawyer was a she. You sign a bunch of papers, and sometimes you're not realizing what you're signing. So if you have documents and you know you have a will, have a look at them, because we want to make sure that you have the documents. The important thing to know about the personal directive is that it only comes into play when you're not able to make your own decisions. And there's a very specific process and paperwork that goes along with that. So it's very important to know that it just kind of sits there. And for a lot of people, they don't even look at your personal directive because you're able to make your decisions right up until death. But if you're not, then that personal directive will serve you well. I always like to think of your personal directive as kind of insurance. We hope you don't need to use it, but it's there if you do. So you can write your personal directive with or without a lawyer. It can look like the form that we've sent out for you. It can look like the Dying with Dignity form. It can look like a piece of paper, as long as it's signed, witnessed, and dated. So we want you to keep the original in a safe place, but remember I told you this is not a secret. So give a copy to your agent, give a copy to your healthcare providers, and make sure your family members have it. So I told you that there is no standard format for the personal directive. You can use any format that you're comfortable with. You can go to a lawyer. The Personal Directive Act wants to make it very easy for you to fill out that form. So there's four main elements to a personal directive, and I thought I'd go through them today. I can't go through everything about a personal directive because I'd be here longer than an hour just on that. So, but the four main elements is that a personal directive is not like a will. So the last one you've written doesn't necessarily stand in terms of date-wise, because you know when you write a will, it's the last one that's the earliest dated that stands. With a personal directive, unless you put on the first part of your personal directive that you revoke any previous personal directives, you can actually have more than one personal directive at the same time. So if you're making a new one, if you're going to the lawyer, make sure that that statement is in there. I revoke all previous personal directives, especially if you're doing it on your own or writing it out or filling out another document. So the other one is in terms of designating your agents. And we had a question that came in before about that. You can have more than one agent, but it kind of matters how you write it out. So you can say maybe you have 5 children and you want to name all of them. So if you say Mary and Bob and George and you go through all down the line, they all have to make a decision together, right? And they have to be notified. It does majority rules if they are to appoint a spokesman amongst themselves that would work with the healthcare providers. Now, for a lot of families, that might not work. If you have 5 kids that can't decide what to have for dessert, maybe that's not the way you go. But if you have 2 children that are very helpful to each other, that know what your wishes are, that are agreeable to act together as your agent, then that might be the best pick for you. For myself, I've chosen to have my daughter and my husband, they're basically the same person, make the decisions together because I think they can help each other, right? And they can be a support to each other. If you put in your document Mary or either Bob, that means whoever shows up first can make decisions on their own, and then they swap up. So if Mary comes to the hospital, she will make decisions. If Bob the next day comes to the hospital, he has the full right to make decisions. So again, this would be a situation where both of these people need to be able to work together. Also, in terms of sometimes for families, it might work because one of those people may work out of town. And so they could swap out between each other, and that might work for your situation. What is suggested on the format given by the Office of the Public Guardian is that you pick a primary agent and then you can pick as many alternates as you want. So that Mary would go first as your agent. If something happened to Mary, then Bob would step up. If something happened to Bob, then whoever you named next could step up. It is a good idea to name more than one. I had a lovely lady who did her personal directive, named her adult daughter, who was a great choice to be her advocate and her agent. The only problem was, unfortunately, her daughter died before she did, and she only named one agent, and then she was left without an agent. So remember, it's great if you can name more than one agent. What we want in a personal directive is you to write out what matters to you. And on the form from the Office of the Public Guardian, this section is optional. For my liking, it should say that you need to write this out, because I think the personal directive is the one document that tells us who you are. It gives us information that we can make medical decisions on. So if you leave that part out, it doesn't give us enough information to be assured that this is the right information, this is the right decision for you. So some things that you can write in there is what's most important in your life. What does quality of life mean to you? What does poor quality of life mean to you? And are there any situations where you would not want your life prolonged? So important questions that you can include in your personal directive. For myself, if I have in my personal directive, if I can't recognize my family over a period of time, then please do not prolong my life. And then I've gone into lots of other details of things I don't want, because working in the medical health field, I've seen a lot of things that I do not want for myself. But there are other people who may write, life is very precious to me, and I want my life prolonged at all costs, right? But you need to make sure that you know what that means. For some people, if you already have a diagnosis, for example, if you already have cancer and have been through treatment, you may be very specific in your personal directive by saying, if I lose capacity, have dementia, then I would not want any more cancer treatment. Or let's say if you're on dialysis, you can put the same sort of thing in your personal directive. So you can make it very personal and to you that speaks to the condition that you are right now. For my mother, she's been very specific and says that she does not want CPR, and that there are certain things that she doesn't want. So she can be very specific. We have a lovely video on our Conversations Matter website of our volunteer, Deb Cook, who talks about her mother who wrote out a personal directive stating what she wanted at her end of her life. And what she wanted was her family around her, music, and that gave the family a lot of comfort because they were able to fulfill her wishes. So we always say that the personal directive is a gift for yourself and a gift for your family because they'll know what to do. So when you're witnessing in signatures, it doesn't, if you do a personal directive by yourself, it doesn't have to be witnessed by a notary. As long as they follow these regulations, they have to be over 18. They should initial where you've initialed. They need to watch you actually sign and date your personal directive, and they need to sign and date it at the same time. So there are some special considerations in the personal directive. A lot of people ask, can I put medical assistance in dying in my personal directive or organ donation? So the answer is kind of yes and no. So for the personal directive, remember, it doesn't come into play until you lose capacity. And unfortunately, you cannot have, at this point, medical assistance in dying when you've lost capacity. So you can't ask for it in the future. When you go to a lawyer, they will not even put it in the personal directive because it's illegal at this time for somebody to perform medical assistance in dying if you've lost capacity. Now, things may change, and I know probably a lot of you are wanting those changes. If you write a personal directive yourself, or if you go to the lawyer and this is something that you want, if the laws are changed, you can put in there, if the laws change, then I would like medical assistance in dying around these circumstances or areas. If you write it yourself, then you can also put that in. Same thing with organ donation. Organs are kind of a funny thing. They actually don't belong to us after we die. They belong to our families, and they have the last say on it. There are certain, if you go on the organ donations website, there are documents that you can fill out that will let us know that you want to donate your organs. You also can do on your license, you can have a star about organ donation, but your final word is for your family. And that's why for organ donation, it's very important you talk to your family about it so that they know and that they're on board on it, because unfortunately they will have the final say. Now, most of the times when a person has gone to the trouble to fill out those documents, have talked to their family about it, the family goes along with it. So also Dying with Dignity on their website, they have their own advanced care planning kit, which I think is really great. And you find it under education and then advanced care planning, and go to the specific province, which is Alberta. They have some great questions in their personal directive that you might want to look at. You could even fill out that kit and then take it to your lawyer so that that information was filled in what you wanted specifically if you go through a couple of scenarios. So it doesn't really matter what form you will use, as long as it's signed, witnessed, and dated, as long as it names an agent, and as long as it says what you want it to say. So those are the important things to know about the personal directive. And our biggest takeaway is don't wait, because the time will never be just right. We have so many people say, oh, I'm going to wait till Christmas when my family's over, or I'm going to wait for this, or I'm going to wait for that. And unfortunately, things happen right in between. And like Dr. Amy Tan, we never know when something may happen. So what I've been talking about is that green bubble that's on your left-hand side. And that's what all of us can do that are over the age of 18. We can think about our values and wishes. We can do that personal directive ahead of time so that we're ready. But when we hit the medical system, if something happens to us, then the hospital and either EMS, the emergency people that come into your home, if you collapse, they need to know what kind of care they should do in the moment. So they need to know what kind of care you want now, not 10 years from now, not when something happens. So if EMS comes into my home, if I've collapsed, they need to know what kind of care that they should be giving. That goals of care is a document that's filled out by your physician, and it should reflect your values and your goals. And that's why all of this is connected, that your physician should be talking to you about your personal directive, what you've put into it, talking to you about what your preferences are to make sure that goal of care reflects what you want. You may be familiar with the American term, do not resuscitate. There's all kinds of terms, but in the province of Alberta, we actually don't use those terms. It's called goals of care. And they're broken into 3 sections: resuscitative care, medical care, and comfort care. The best way to explain the goals of care to you is actually to show you a video, because goals of care is actually things that we do to you or don't do to you. And so the best way of seeing that is through a video. Now, I want to give a warning. You can step away if you're squeamish, but this video is actually done in Calgary with local people. The person that they're giving CPR to is actually a dummy. The ICU scene is actually done in a lab. So nothing in this video is real, but some people, if you've been in ICU, it may trigger a really emotional feelings in you. So if you need to walk or step away, I can't see you, so you're free to do that. The movie is approximately about 9 minutes long, just under 9 minutes. So if you need to step away, please do.
Goals of care are designations used by your healthcare providers to describe the general aims of your healthcare and the preferred location of that care. Decisions about goals of care usually arise over time through conversations between you, your family, or loved ones and your healthcare team. The process of thinking about, talking about, and documenting your wishes for healthcare is called advanced care planning. In a medical emergency, your goals of care designation guides your healthcare team to provide timely care that is both medically appropriate and reflects your personal values and wishes. There are 3 general approaches to care or goals of care: resuscitative care, medical care, and comfort care. In resuscitative care, the main goal of care is to prolong life by curing or controlling your health condition. This means that doctors and nurses could use intensive medical and surgical interventions, if these are needed, to keep you alive and could be expected to cure or control your illness. If your heart stops, they may perform cardiopulmonary resuscitation or CPR. You may have seen resuscitation or CPR performed on television or in the movies. The person usually recovers easily, but this doesn't tell the whole story. Resuscitation measures like CPR work best in emergency situations where the heart stops suddenly, but the person is otherwise pretty healthy. It's important to know that CPR normally cannot restart the heart or restore life when the heart has stopped as a result of a severe or terminal illness. In CPR, the doctor or nurse repeatedly pushes on the chest with great force and periodically puts air into the lungs. Electric shocks, called defibrillation, may also be used to restart the heart, and some medicines might also be given. If the patient's heart starts to beat again, most patients require a stay in intensive care and a period of rehabilitation before they are well enough to leave hospital, and some people are left with permanent damage from their heart stopping. Resuscitative care can also include using medications and other treatments that are provided in an intensive care unit or ICU. The ICU is a very specialized unit in a hospital with doctors and nurses who are trained in using special equipment and medications to care for very sick people. An intervention that may be used in the ICU to prolong your life is a ventilating machine. These machines are used if you're unable to breathe on your own. This means putting a tube which is attached to a machine down the throat into the windpipe to push air into your lungs. Because this tube can be quite uncomfortable, people are often given medications to keep them very sleepy or sedated. You cannot eat or talk while on this machine. If you have a potentially curable or treatable condition, ICU care might be needed to help you heal. The hope is that you will return to your previous health, but it is important to understand resuscitative care and procedures used with the aim of prolonging life may or may not achieve that aim of restoring your previous health. In medical care, the goal of care is also to prolong life and to cure or control your health condition, but without the use of resuscitative care and the ICU.
Good morning, Mr. and Mrs. Johnson. How are you this morning?
Medical care can be appropriate if your health condition is such that intensive or resuscitative care such as CPR and a breathing tube are unlikely to work. Or your wishes and values about healthcare may be that you would not be accepting of these intensive medical treatments. For example, if they are unlikely to restore you to a state of health that you would want. In the medical approach to care, your doctors and nurses will provide tests and treatments for any treatable problems that may arise. This approach may include surgery and medical treatments such as blood transfusions, kidney dialysis, feeding tubes, antibiotics, and other medicines or fluids given through your veins. Most of these treatments mean going to the hospital.
Of course. You know how much she loves dance. Okay.
Hi,
So, of
Pat.
course,
Good afternoon.
Some people want to receive only the life-prolonging treatments that can be provided in their home or in the care center where they live, even if this limits what treatments are possible. If your goals include a desire to avoid going to the hospital for treatment, talk to your doctor about what treatments may be available and helpful to you in your home or care center. When your health condition or your values and wishes reflect a goal of maximizing comfort and relieving symptoms, this approach is called comfort care. Your doctors and nurses will give you medicines and other medical treatments to help control uncomfortable symptoms such as pain, trouble breathing, or feeling sick to your stomach. The main goal is not to prolong life, it is to maximize your comfort. Resuscitative treatments are not used. Comfort care does not mean that you receive less care. It means the focus of your medical care is on quality of life and reduction of symptoms. People receiving comfort care are usually treated at home, in hospice, or in a long-term care center. However, sometimes hospitalization may be needed to provide optimum comfort.
You know, he feels a lot weaker when he can't keep anything down.
In the hospital, the approach to care will continue to be focused on providing comfort and relieving symptoms. It's helpful to keep in mind your wishes and to know about your own health condition when you are discussing goals of care. Resuscitative care, medical care, and comfort care can be divided into more specific subcategories called goals of care designations. These subcategories provide your healthcare team with important information to help guide medical decisions about your treatment. Talk to your healthcare team about which goals of care designation best reflects your wishes and health circumstances.
So I'm just going to talk about the goals of care and how it works. Don't worry, you don't need to memorize this information, and it's not meant for you to know all the goals of care and pick one. It's meant that when you're having conversation with your physician, that you'll understand a little bit better what goals of care mean, and that you'll know what your goal of care means. So this is the goals of care designation order form. If you have a green sleeve, then that's what's included in your green sleeve, or maybe you've gone to the hospital and you've left with a green sleeve and a goals of care designation. So this is the form that the physician or a nurse practitioner completes. You do not sign this, you do not fill it out yourself. This is the form that they fill out after they've had a discussion with you, and they choose along with you the goals of care, and it even has a tick box on there saying that I've talked to the patient about the goals of care. So the goals of care is a medical order, right? It's something that the physician writes out and that we follow. So not everybody needs a goal of care. I don't have a goal of care. So if something happened and I collapsed, the EMS would do absolutely everything that they could do to save me. And that's the same thing would happen in the hospital. So don't worry about if you don't have a goal of care, or if we can't find your goal of care, we're going to err on the other side. We're going to do everything that we can until we find out differently. So not everybody needs a green sleeve. I don't have a green sleeve because I'm relatively healthy, and at this time I'm an R1. But if you have health conditions, if you feel you wouldn't benefit or don't want resuscitative care, if your health care is changing, or maybe your values and maybe your goals are changing, then that's when you should be having that discussion with your physician. So the goals of care are broken up into resuscitative care, medical care, and comfort care. I'm going to go through them so that you have an idea what it means if somebody's talking about R1, R2, or R3. So R is the resuscitative care. How aggressively are we going to resuscitate you is basically what it means. So for R1, it means we're going to do absolutely everything. We're going to give you CPR. We're going to give a tube down your throat to help you breathe if you need it. We're going to be taking care of you in the ICU if that's what's needed, right? And usually if you're getting a tube down your throat, you're in the ICU. R2 is we're going to do all of that, but we're not going to do chest compressions because maybe that won't work for you. And R3 is that we're not going to do chest compressions or intubation, but we're going to still take care of you in the ICU. And I'm going to give you some examples so it'll be a little easier. So remember I said I'm R1 and we don't need a goal of care or a green sleeve for that. Everybody's R1 until we know differently. So this gentleman, I've been in a car accident. I am relatively healthy and I'm going to get whatever treatment that will make me better. I don't know what the outcome will be, but I want to prolong my life at all costs. So that's just an example of what an R1 would be. R2, I know that chest compressions will not work for me, but a breathing machine in intensive care will get me back to my active lifestyle. And this gentleman has figured that out through discussions with his physician. R3, I suffer from afibrillation, right? Afibrillation is when your heart doesn't beat properly and it needs to be shocked back into a rhythm back to a normal rhythm. So sometimes I need to go into the ICU, the intensive care unit, remember the video, to get my heart rhythm back on track. I do not want to receive chest compressions or be on a ventilator, as they will not return me back to a state that I value. And so remember, we're not looking at what CPR does, we're not looking at what ICU does, but we're looking at what does that mean for me and what will I look like out in the other end, right? In terms of, remember the video, not everybody can benefit from CPR, and a lot of people will actually end up worse than they were before. So the next one is medical care. So this is for people that don't want to have resuscitative care, so no CPR, no intensive care unit, and no intubation, that tube down your throat. So for M1 is all the interventions, including transfer to acute care. M2 is interventions, but this is for somebody who usually wants to stay home. So just an example of M1, I'm willing to go to the hospital for any appropriate medical and surgical treatments to try to fix the fixables. I would like to live as long as possible and maintain my quality of life. CPR, ICU, and the ventilator will not help me, and if attempted, will not leave me in a state of living that I value. So my mother, when she was 89, knew she didn't want to have CPR, went to her family physician and got that order of M1. And then I was shopping with her and she had a stroke. So I think I'm doomed, both sides of stroke. We went to the hospital. They were able to unblock her, the blockage that she had. She didn't get CPR. She didn't get ICU. She didn't get a ventilator, but she got everything that they could to make her better. And unfortunately, she wasn't able to return home, but she's in long-term care. And most of the reasons is of mobility issues, but she's doing really well in long-term care. So in long-term care, my mother's gone into long-term care, and that's when we've changed her goal of care to M2. And the example is, I want to be treated where I live and not go to the hospital. I won't want medical treatments that are available where I live to try to fix the fixables. When I go to the hospital, I just get worse and they cannot fix me. So what my mother has can't be really treated in the hospital. She's in long-term care. She gets medication for her blood pressure. She gets other medications. She gets pain medication. She goes out and gets shots for her macular degeneration. And so she's getting the care that she can where she lives. And that is doing fine because she knows actually she gets in a really bad delirium if she goes into the hospital, and it actually makes her worse. So that fits for her and the diagnosis and prognosis that she has. So the next one is comfort care. So now the focus isn't on curing, but rather we're looking at keeping people comfortable and making sure that their symptoms are in control. So people in a fallacy, if they're C1, is that if for comfort care, we can give you oxygen, we can even have surgery, we can do anything that's going to make you feel comfortable. It's not going to cure you, but it's going to keep you comfortable. So for C1, the focus maybe is to provide comfort and to treat my symptoms using whatever medical treatments that will maximize my quality of life rather than focusing on the length of my life. I may be at this level for months or years. So we have lots of people that I have seen some people that are C1 went into hospice and actually were discharged from hospice. And they were getting the medications that just treated their symptoms. They weren't getting chemo. Let's say an example of somebody who has cancer. Maybe you have a tumor and they may choose to remove that tumor. It's not going to cure the cancer, but maybe it's going to have you breathe a little easier for the time that you have left. So you can have all kinds of treatments on C1 that's not curing, but it's actually treating the symptoms. For C2 is for someone who's in the final hours or days of life, and all treatments are focused on comfort and support of the family. And this is an indication that they shouldn't be moved, right? So somebody in hospital, even if they're waiting for hospice, we wouldn't move them because we would know that they would die en route. I do want to say a bit about palliative care because people ask, do I need to be comfort care for palliative care? And palliative care is philosophy, and that is available for everybody, all the goals of care. But if it's someone who has a life-limiting or life-threatening illness, so you can have R1, you can have cancer, having treatments, and have palliative care, because palliative care is looking at symptoms and making sure that your life is as best as it can be. So what are the next steps? The next steps is talking to that physician, finding out what your disease process is, if you have one, looking at what your medical condition is, do you understand it? We have some lovely decision tools on our Alberta Health Services website, on My Health Alberta. You can look at, should I receive CPR? Should I stop kidney dialysis? Should I stop treatment that prolongs my life? So there's different tools that you can use. There's also things that you can think about, like what would you like to know about your illness and what is likely to be ahead, right? So that you can ask your physician some of these questions, or tell them, or what is most important for you to have a good quality of life. These are important things for your physician to know. What are you afraid of? And what kind of medical care that you do not want. And so things that you can ask your doctor, what will this illness look like in a month, in a year? What treatments will help me live the way I want? We have a story of our manager, and her mother had cancer. Unfortunately, they put a shunt in, didn't really have a really good discussion with her. And then afterwards, she found out she wasn't able to travel with that shunt. And if she would have known before, she wouldn't have had it, because she wanted to visit her relatives in England before the end of her life and wasn't able to do that. So it's very important that the doctor know what your condition, that the doctor know what your goals are for your life. I'm going to play a short video. It's only 3 minutes. And this is a gentleman talking about having that conversation with his doctor. It's a real person. Again, it was filmed in Calgary. And unlike the other film, that he's not an actor, this is a real person talking about his situation with goals of care.
Well, I was diagnosed with pulmonary fibrosis in December of 2006, actually. And that was after about 5 months of various testing. The type there's no known cause for, and there's no cure. So it's a terminal disease. And it becomes very stressful when you're dealing with that sort of end-of-life disease. And knowing that there's no cure, it's progressed to the point now where I can do very little work, very little exertion, and I'm wearing oxygen 24 hours a day. Dr. Fell sat down with my wife Moira and I, and we talked about the different levels of care and got a good understanding of, if things progress to the worst, what did I want to see happen? And how did I want the medical team to care for me, and what capacity? And the good thing was that my wife was there, and we were able to discuss it, and she agreed upon it as well. So to come to a time when that decision had to be made, she knew exactly what the decisions were. Advanced care planning is a very difficult thing to do, and over the past number of months, my experience with advanced care planning has improved, and my knowledge has improved considerably. My wife and I have a personal directive that was made several years ago, and I view the personal directive a little differently when it was done in that context. It's maybe a broader scope document, where this is a living document, and it engages not only your family members, your medical team, and yourself. And so it's a team effort as we kind of go through this process. And it's, you know, I think it's been a good experience for us, and one that that I don't regret at all going through and doing and working through with my wife and family. As I say, it's one of those topics that you can easily procrastinate at and say, well, tomorrow is always a better day to talk about that. I think the advice that I would offer to someone that didn't want to get involved would be more to think beyond yourself and think about your family and to think about what value something like this provides.
So I'm going to push on because we're getting short of time here. But a lot of people ask in terms of where does medical and assisted dying fit with all of this. So remember we talked about the personal directive in terms of you can put in it, you know, you can request it, but at this time we can't follow through. But in terms of your goals of care, there is a spot for it, and that you would be C comfort care if this is something that fit with your values and wishes. So we have a lovely website for medical assistance in dying. All your questions can be answered on there. If you just look up medical assistance in dying, Google medical assistance in dying in Alberta, this website will come up. You can also call 811 and they will direct you in terms of any questions that you have. So remember in the video, and I talked a little bit about the green sleeve, this is the actual green sleeve. This is where you keep all your documents. This is where you keep your copy of your personal directive. And this is where you keep the original of the GCD order form that the physician has filled out, and the tracking record, which is for your medical providers that would be writing something about your advanced care plan, whether it be your goals of care or filling out your personal directive. So why do we still need that plastic cover? Well, in the province of Alberta right now, we have 1,600 different medical computer systems, and unfortunately, none of them talk to each other. So the only way we have of knowing about that conversations you've had with your physician, about that medical order, that goal of care, is the paper form. So that's why we want you to make sure that you have that green sleeve with you. You take it to emergency, you take it to your appointments. My mother is in long-term care. When we leave the premises, we used to go to the mall, not so much anymore, or when I take her to my home, I make sure she's got the green sleeve with her, because if she collapses, I want to make sure that the EMS know what kind of care to give her. So some of the questions we have is, do I have to carry this everywhere with me? And my mother's a good example. We don't need to, but then EMS isn't going to know what kind of care. It would catch up eventually. But so if that goal of care is important for you, then it's important that you carry that information with you. And we don't have a smaller wallet card, but you could fold up the goals of care and put it in your wallet or purse. But you need to make sure that people know where you have it. You can make copies of it and make sure your family have a copy of it. And no, we just don't know your goals of care. If your goals of care was determined in, let's say, Foothills Hospital here in Calgary, and you went into Peter Lougheed Hospital, Peter Lougheed Hospital has no way of, right now, of getting your record from Foothills. Some people know about Netcare. Netcare is just a depository of medical information that physicians have access to. But again, if it isn't updated, we don't know for sure when was the last goal of care conversation when you had that. Medical alert bracelets, that would be a great idea, but unfortunately it's not a medical order. We don't know if your goal of care was changed after you had that bracelet, and it's not easy to change on a bracelet. Some people have a capsule of life. That's the issue with the capsule of life also. Capsule of life is just meant for information to be put into a spot where emergency people can find it, but it's not a living document like your green sleeve is. Because remember, we wanted to take it out, we want to make sure people know where it is, and we want to make sure if you go somewhere that that follows along with you. So there is a video on our website about the green sleeve. I don't have time to show it today because we're running short and I want to give time for questions. So the 3 takeaways is don't wait, and make sure you're involved in those discussions, and that your green sleeve is your medical passport. All our information is on our Conversations Matter website, so that's what it looks like. If you go to the Patients and Families tabs, it'll take you to all kinds of great information, including our Conversations Matter Guidebook, which we sent you out a copy with. It goes through all the information, including those 7 goals of care that I talked about today. So if you look through it, read it, it talks about the personal directive also and what to put in it. You can take it to your doctor and start the conversation. If you're going to visit your doctor, please make a separate appointment. Let them know that this is the kind of discussion you're wanting on it. So I'm going to stop now so that we have some time for questions.
Thank you so much, Alexandra, for all of this very valuable information. I learned a lot, and I suspect our audience learned a lot as well today. So there have been a few questions coming through. One is about the green sleeve. So through Alberta Health Services, is there a place to order your green sleeve to be delivered to your house?
Yes, so you can. So great question. On our Conversations Matter website, if you go to the Patients and Family tab, there's a green sleeve tab that it tells you how to order it. It's an automatic process, and it's up to 2 green sleeves will be delivered to your home. Also, your family physician should have some, but not always. So if you want to, the easiest way to do is just have them delivered to your home if you'd like. And in there would be all the information that I talked about today.
Fantastic. Great. Okay, so a question that came through is from somebody asking, what happens or what should a person do if they don't have anyone to be their agent, no friends or family who could act as that person?
Great question. You can do a personal directive without naming an agent. Make sure somebody knows where it is or give it to your healthcare provider. Then we would be obligated to still follow your wishes in the personal directive as healthcare providers. If you feel that you would like to name someone, remember it doesn't have to be family or friends. Sometimes people have named the manager of their building, but it does need to be a name, and if sometimes that works. Or if you still feel there isn't anybody, you can call up the Office of the Public Guardian. If they agree to it, then they will be your agent if you lose capacity. So there is a couple of options there.
Great, thank you. Another question. So what if a person lives in Alberta and say their relative lives in Ontario or their relative is in the US? And that's the person that they would like to be their agent. Can they still choose that person who's out of province or out of country, or is it better to find somebody local?
So you can choose anybody in the world, actually, as long as we can reach them by phone. But for certain things, like if you think that person needs to be able to come into Calgary, let's say, to be in the hospital, then it's more advantageous to pick someone that lives in Calgary. But it don't necessarily need to. I know lots of people whose children are scattered around the world. We can do Zoom, we can do Skype, so your physician would still be able to talk to your agent through Skype to be able to make decisions for you. So there are ways to do it. And a lot of people talk to their relatives over Skype or Zoom on a regular basis, and they actually know them better. I mean, literally now with a computer, you can take them with you to a medical appointment. So it's basically who we can contact easily and who knows you best. So that can be anybody in the world.
Right. Technology can be helpful in that situation.
Right? We have lots of physicians who are doing this conversation over Zoom. So that's quite exciting. Because of COVID, they're not able to come into the office. So they're actually having these conversations about goals of care and dropping off the documents at people's doorsteps. So it's been really helpful.
Now, this was the time we were supposed to wrap up. Alexandra, do you have a few more minutes?
I have extra time, so
okay.
There's nothing booked. I'll stay as long as people want to stay.
Okay, so we have a few more questions we can go through, and again, if people do have to run because they had an hour booked in their calendars, this will be recorded so you can watch it later. Now, you did mention that people can choose their sort of first choice for their agent and then an alternate just in case something happens. if a person is struggling to decide who should be my first choice and who should be my alternate, are there any discussions that should be had, or characteristics of that person that a person should keep in mind when trying to make that decision?
Well, they should be able to advocate for you, so know you best. And a lot of people even take somebody they picked as an agent to some of their medical appointments. They should be able to do well in an emergency, and able to speak English well. So it's an advantage. Unfortunately, it's just the way that things are in the medical field. If you have to talk to a lot of medical people, unfortunately, not all of them have a second language, so that English is advantageous. But that being said, if you can't choose between two people, can you talk to them both? Maybe one would not want to be the first pick. Maybe they think that they can do it together. So there is not a right answer. It's the right answer for you and your family. Like I said, for myself, I've picked my daughter and my husband, and for another family, that might not work, but I know that that's going to work for me and my family.
Great. And if somebody does decide to have the person A and person B scenario, so they both are agreeing on the decision being made for that person, what happens if there is an issue with those two individuals agreeing? Could you share a little bit about what that process looks like if person A and B just cannot come to the same decision?
Well, first of all, they're going to follow the personal directive. So if there's instructions in the personal directive states your agents, even if they don't agree with it, are going to follow. So if there's nothing in the personal directive that talks to the situation, and if there is a true situation where there's two people that are and they can't decide, unfortunately, it could end up in court, because then we're kind of at an impasse. If the physician feels that one of the agents is not doing the decision in the best interest of the patient, then they can report the agent to the office of the public guardian, right, in terms of that they're not acting in the best interest of the person. So there's numerous ways. Now, we don't want to get to that. I think usually I'm a social worker, and usually people can come to an agreement about it. There's very few times. And specifically, if you've been very open with your family and have told them what you want, then that's what we don't want. And usually it's not that they're bad people or that they want to do you wrong, it's they just don't know what you want. So that's why that personal directive and those conversations are so important.
And if somebody doesn't name anyone to be their agent, maybe somebody is quite a bit younger, they don't think that they're going to get into a situation where they've lost capacity, what happens if nobody is named? What's sort of the alternative to that?
Are you thinking that they don't have a personal directive at all?
That's right, yeah.
So if you don't have a personal directive at all, take my friend, Dr. Amy Tan. She'll end up in an emergency. The physicians can do what they feel is appropriate for medical care in an emergency situation. And then until her husband arrives, then they appointed him on a form, what we call a Form 6. They have the ability to do that. It's a legal document, and the physician picks who would make decisions for you. So there are ways to do it, but let's say, you show up, an emergency can't tell us, then we're going to do the best that we can for you. And it's usually two doctors are going to make that decision.
Okay. So in this doctor's case, her husband was assigned. Is there a hierarchy in place that
yeah, there is. There's a hierarchy, so it goes husband-wife, including common law, and then it goes down the line. But they're all blood relatives, so it goes, could be sister, brother, could be parents, could be uncles, aunts, and it goes all the way down to grandparents. So it's going to depend on the age, but the physician has the discretion in terms of appointing somebody who's appropriate. So let's say we have a 90-year-old come in and wife is 94, he can skip over wife and appoint an adult child or even an adult grandchild if he thinks they're not able to make the decisions for the patient.
Helpful. So you mentioned as well that if you're filling out your documentation around advanced care planning, you can have a lawyer involved if you want to, but it's not necessary. There's just those requirements with witnessing and dating and all of those pieces. If somebody does want a lawyer's eyes on it, just to make sure and have some extra reassurance that they can't afford a lawyer, do you know of any resources at Alberta?
For seniors, we have a couple of resources there's the Kirby Center, and they have lawyers that volunteer there, and actually Kirby Center will help you do those documents, and also legal guidance will also help you with documents if you need that, and legal guidance will help you with the will and enduring power of attorney and the personal directive.
Yeah.
So, but usually if you're going to a lawyer, the best thing to do is to negotiate a price for all three. It's kind of a three-fer, so that you know up front what the cost would be. If you know that, then they're not going to charge you any more or any less. That would be the set price for all the documents. So that's just kind of a tip in terms if you're wanting to, and you can shop around with different lawyers in terms of how much they would charge for doing those documents.
That's helpful. Thank you. So one last question before we wrap up for this afternoon and for the weekend. Happy weekend, everyone. If you could just go over the organ donation piece again, just to get some additional clarity. You said that after you die, your organs belong to your family, not to you anymore. So is it most important that people have those discussions with their families about what they would want their organs to be used for?
So a disclaimer, I'm not an organ donation specialist, but I do know, because lots of people ask us in terms of organ donation. So the best thing to do is fill out the documents that you can get online, or go to your motor vehicle branch in terms of they have them there. You fill them out, you make sure that people know about it, but it's that conversation that matters the most, so that your family knows that that's what you want. My husband has done it in terms of attached it to his license, and he made sure that I knew about it, because I think it would be quite a shock for me if I didn't know that that's what he wanted. And I think that's what happens with most families, if they're not sure if that was really what you wanted, was it a mistake? But if you have that conversation with your family, say, look, this is really important to me, so if something happens, make sure that this happens. And like I said, most of the time families are quite agreeable, and things go like the way you wanted it to. But if they don't know about it, then it puts them in such a kind of a funny position, right?
For sure. No, that makes sense. Well, we will wrap it up for this afternoon. And Alexandra, thank you again so much for joining us and for your incredible presentation. It really was very helpful, and I think there will be a lot of fantastic takeaways for people who haven't had these conversations and haven't started the process, and also those who are continuing to work through their advanced care planning as time goes on. And thank you to the Dying with Dignity Canada Calgary chapter for organizing this event, and to all of you, all of the fantastic attendees who are here with us this afternoon and who sent in your questions. We're very glad that you could make it, and like I said, have a great weekend and enjoy the fall weather.